Okay, so my name is Madani. For those of you guys that don't know me, I'm a second year here. Today I'm going to do a lecture on ectopic pregnancy and intrauterine pregnancy confirmation as part of the ultrasound review series. So let's dive in. So this is a quote from the ACEP policy comments. It says, emergency medicine physicians frequently evaluate and manage patients with abdominal pain and or vaginal bleeding in the first trimester of pregnancy. Their primary concern in this group is to identify ectopic pregnancy. Starting with some of the goals for this lecture, I want to make this less stressful for everyone in the room. You're working a pod shift and you see this on the board and you know that your workflow is about to get way more challenging. Seeing these patients is emotionally taxing. You're going to be working with patients who may be, grieving mothers. It's going to be requiring you to have some level of coordination that was kind of unexpected in terms of getting a room set up, making sure you have a chaperone in place. And on top of that, there's going to be a lot more clinical reasoning when you're approaching these patients. So I want to kind of help create a framework that can guide you through the management of these patients. I want to talk about the pitfalls in the management of ectopic pregnancies, and then go through an algorithm for the first trimester vaginal bleed. And finally, we'll be talking about identifying an IUP on ultrasound. So to start off with our case, you have a 21-year-old female G3P1, last menstrual period was 4 weeks ago, with a positive UPREG at home presenting with vaginal bleeding and pelvic pain. She was recently evaluated for pelvic pain associated with vaginal bleeding at an outside hospital yesterday. At the time, the beta HCG was 370. A gestational sac with no fetal pull or fetal heart rate was noted. However, there was mention of a visualized yolk sac on the report. She brings you the report she has the report with her. And today she has episodes of nausea and vomiting with constant left-sided pelvic pain with vaginal bleeding. Rest of RS was negative with vitals that are down there, hemodynamically stable. And so I had this patient, and she was in the pod. She was essentially crying in distress, crying in pain and in distress. On exam, she had tenderness over the left pelvis with voluntary guarding. She refused the pelvic exam. We got labs almost immediately for her. The hemoglobin was 11.7, hematocrit 34.4, HCG was 391, uptrending from the 370 yesterday. And then, she was completely in distress and did not look good. So immediately had a bedside fast, but already started thinking of like the next steps for what we might have to do for the patient, including getting a transvaginal ultrasound or putting in a gyne consult. So this was her fast exam at 10:34 p.m. This is the last thing that I was able to do for this patient. I remember putting in the scan, getting the fast done. The fast was, we're looking at the right upper quadrant, left upper quadrant, the pelvic scan as well, obviously looking for any free fluid there. And the fast was negative, and I remember she was in so much pain that she was literally just saying, like, I don't care, what is going to happen to this pregnancy, just give me anything to take this pain away. And I remember putting in the order for morphine, the note was in, the patient was signed out, and I went home and woke up the next day and logged on to Epic, not to finish writing notes or anything, but generally because I was very curious to see what's going on. And this was the transvaginal ultrasound that was done. This was 5 hours later at 2:48 a.m. And the read here was a left adnexal region incompletely characterized, heterogeneous tissue with internal vascularity, with no definitive characteristics of appearance for ectopic pregnancy. However, ectopic is not excluded. Close correlation with laboratory values and clinical history suggested there was moderate to large pelvic free fluid that demonstrated internal echoes and debris that was non-specific but concerning for hemorrhagic material. There was a left ovary that was suspected with involution and hemorrhagic corpus luteal changes. And I was very shocked because, in this setting of, a patient who's in that much pain with a positive pregnancy, HCG is like 390, and obvious, moderate to large free fluid in the pelvis. You would think that, the next step here would be the patient going straight to the OR. But this is what happened next. We had a CT abdomen pelvis at 3:28 a.m. This demonstrated a large left adnexal pelvic hematoma measuring 5 by 6 centimeters with adjacent free-flowing hemorrhage within the pelvis that may represent a ruptured ectopic pregnancy with hematoma or a ruptured hemorrhagic cyst. They recommended a gynecological evaluation. At this time, I think gynecology was already on board. I was kind of confused about why the CT was done. I remember reaching out to the person who had taken over this to find out what was going on. But I guess the gynecology team wanted to further characterize what might be going on. And I really was a little lost. I was like, man, like, do I have a poor understanding of how we manage ectopic pregnancies? Like, is our CT and pelvis somehow now part of this framework? But they're actually not, and I don't think this patient needed to get a CT out in pelvis, especially over 7 hours into her stay. So this case really got me curious, and I dived into some of the literature on this, and one of the papers that I really wanted to focus on during this talk was this one. It's a retrospective study over 18 months from the University of Colorado in Denver, that examined factors associated with delayed diagnosis in 65 patients with ectopic pregnancy. Essentially, they did a chart review. There's 2 groups that were divided. Patients who were admitted promptly and admitted onto the ED during their first visit were Group A. All Group A patients received surgery within 24 hours, and Group B patients who had a delayed diagnosis or treatment of their ectopic pregnancy. All Group B patients also had a delay of surgery of at least 24 hours. So they essentially talked about the 10 common pitfalls that we have in our practice. And one of the ones that they had listed was absent pain. They said that lack of pain does not exclude ectopic pregnancy. They noted that the vast majority of the histories that were documented of intermittent or vague pain, physicians actually failed to pursue. Essentially, they looked at nursing notes that listed the patient was in pain or had mentioned pain, but the physician notes didn't have any mention of that. And sometimes it was atypical pain that was described, such as crampy pain or pain similar to my miscarriage. And I thought that was interesting. I think really getting that piece of history is so important when you have patients who are pregnant with vaginal bleeding, whether or not they're in pain, is kind of a fork in the road in terms of how you will manage these patients. But it was interesting to find that sometimes patients who have no pain can still have ectopic pregnancies. There was one of the other pitfalls was adnexal masses on the PE on the physical exam. So essentially, half of patients with ectopic pregnancies have palpable masses, and 1/4 of the palpable masses that were found on the study were actually on the site opposite of the ectopic pregnancy that was found on laparotomy. So this kind of made me think a little bit about the physical exam that we do, and how good we are at actually performing these exams. In this study, I mean, people literally palpated masses that were on the opposite side of the ectopic, and I thought that was pretty interesting as well. Underdiagnosis of subtle blood loss and rationalization of clinical signs of hypovolemia. So, and essentially, the patients that came in either had drops of their hemoglobin, and instead of attributing this to potential ectopic pregnancy or vaginal bleeding, instead they were attributed to like signs of dehydration or essentially the possibility of blood loss was actually never really pursued in these patients. Failure to recognize risk factors. Essentially, many of the risk factors were never really documented or pursued in some of these visits, those being like previous GNC diagnosis, tubal ligations, smoking history, IVF, and previous ectopics. The assumption that passage of fetal tissue indicates completed abortion. So essentially, patients were describing passage of tissue, and physicians were essentially just attributing that to, like maybe that was a product conception and this is a miscarriage, and the workup's kind of complete. Failure to find an IUP on transabdominal ultrasound. So many times there'd be an empty uterus, and the patient would essentially get discharged or for potential fetal demise or miscarriage. But really, an empty uterus is exactly what you do see in many ectopics. So essentially, that was also interesting to know. And then misinterpretation of transabdominal ultrasounds. So many times adnexal masses or cysts were just, there were findings that may have been concerning for ectopics, but they were just noted as cysts or masses on their studies. And there was, I guess, no real documentation of true intrauterine pregnancy, which I think is what happened in the case that we had. And then finally, dependence on HCG was another one that I wanted to include on here. I think we really depend on HCG so much, but one of the characteristics of ectopic pregnancies is that we really can't use some of the cutoffs that we think of, because these pregnancies are non-viable and they're not really producing HCG at the same rate that true pregnancies do. So this is just a quick framework that I drafted here. So if you have a patient with first trimester vaginal bleeding, first trimester abdominal pain, you're going to want to get a transabdominal ultrasound. And here you're really thinking, is there an IUP or no IUP? And a good rule that I think I've heard multiple attendings mention is, every pregnancy is an ectopic until proven otherwise. One of the things I kind of want to dive into was our physical exam, kind of working our way down this framework. This study here was essentially looking at whether or not how good our physical exam and history actually is in diagnosing these patients. This was at Duke University. They reviewed 14 prospective studies that were published between 1988 and 2011, examining the diagnostic utility of clinical findings, laboratory tests, and transvaginal ultrasonography for the identification or exclusion of ectopic pregnancies in over 12,000 patients that were hemodynamically stable with abdominal pain, pelvic pain, or vaginal bleeding. And they found that no individual characteristic on physical exam was really that good. All components of the patient history and symptoms showed a limited clinical value with all likelihood ratios less than 1.5. Their conclusion was that individual history and clinical findings are unreliable when viewed in isolation as indicators of ectopic pregnancy in hemodynamically stable women presenting with abdominal pain and or vaginal bleeding, and that transvaginal ultrasonography and quantitative serial beta HCG testing are useful if ectopic pregnancy is suspected in these patients. I also wanted to kind of dive into labs and the number that we really think of, the discriminatory zone number. Does anyone want to talk about what the discriminatory zone is? Does anyone want to chime in and give their definition of it? What is the discriminatory zone when it comes to HCG? Does anyone know?
The level that you would expect to see an intrauterine pregnancy.
Exactly, right. So it's the number, essentially the HCG number at which you should be able to see a viable intrauterine pregnancy, and that's it, just an IUP, not an ectopic. So I thought about this a lot, and like as an emergency medicine physician at the service level, this number really doesn't mean that much to me. And the only reason that I should know about it is so that I can advocate for a good standard of care for the patient. And what do I mean by that? In the setting of getting a study protocol by radiology, it means being able to say something like, I know you might not be able to visualize the intrauterine pregnancy at this HCG level, but I'm actually worried about a different process. Or in the setting of speaking to the gynecologist, you can say, I know there's no visualized IUP or ectopic pregnancy, but there's free fluid in the abdomen and the patient is in pain, and I'm worried there's something that we're missing. Essentially, going back to the study that was done and looking at this, and looking at the true definition of the discriminatory zone, the HCG value really doesn't give us that much information on whether or not you have an ectopic pregnancy or not. So the next step here is actually finding the IUP. It's the next thing that you would do after you've talked about, the physical history, physical exam, the labs, and now you're trying to find and localize intrauterine pregnancy. And how do you do that? So the basics, the probe that you're going to want to use here is the curvilinear probe. I have an anatomical schematic on the right of the screen where you can see the probe is placed down. You're looking for the pubic symphysis. You're getting this long axis view here of the bladder, the uterus, the sacrum, cervix, and vagina. And then we're going to use this anatomical drawing to kind of follow through the rest of the scan. So side by side here, this is the view that you see on the ultrasound, just like a mock-up sketch of it. Note it's important to know that you're going to get the best view with a full bladder, and that the bladder may lie midline and the uterus may lie a certain distance off the center. So really what you're going to do is you're just going to adjust to the left or right as you need to get this view. Following that sketch, you can kind of see the true ultrasound image on the right of the screen with the schematic on the left. So again, you're looking for the bladder, you're looking for the uterus, the fundus, looking for the endometrial stripe, and trying to get this perfect view of the uterus to find the IUP. This is just a pan through the view here, long axis view. And then you can turn your probe essentially 90 degrees counterclockwise and sweep again for the transverse view of this of the same thing. And here you can see the anatomical sketch. You're going to see the uterus, the bladder, vagina, cervix, and then on the right you see the mock-up sketch and the true image on the right here. And then have another pan through as well. If you're wondering what this structure is in the center right here, it's actually just the IUD that was in place during the scan. So one important thing is when you're doing a scan, if you scan too deep into the pelvis, you may actually see a vaginal stripe versus the endometrial stripe that you're looking for. And one way to distinguish these is the vaginal stripe is going to have a line running left to right, whereas the endometrial stripe actually has more of like an oval shaped appearance. This is the one on the right is what you're going to be looking for. So if you find yourself too far down in the pelvis, you can move up and get the endometrial stripe. So there's three things that you must find on this scan to actually call something an intrauterine pregnancy, and that is the decidual reaction, gestational sac, the yolk sac, or you can find a fetal pole with fetal cardiac activity. So I'm going to go through all of these one by one. Decidual reaction is just a fancy word for the echogenicity that you see here that's formed from the HCG that's secreted in the endometrial lining. So essentially you have an IUP or an ectopic pregnancy that's causing changes to the endometrial layer inside the uterus that's giving it this echogenic ring like structure. So that's one of the things you want to look for, the decidual reaction. And you can see like this mock-up here on this side. Next, you're going to find the gestational sac. So the gestational sac essentially is just the pocket of amniotic fluid where the fetus will reside. So you have your decidual reaction, you have your gestational sac here, and then the yolk sac as well, which is right there. So when you have the gestational sac with the yolk sac, that's what's termed the double ring sign, which is the earliest sign of a definitive IUP, which usually becomes visible when the gestational sac is about 20 millimeters in diameter. So again, looking for this decidual reaction, looking for the gestational sac, which is the amniotic fluid inside that, and then the yolk sac as well. So if you see all three of these things, you have an IUP that's confirmed, as long as it's all inside the uterus. And then another thing, right? If you can't find that, you might also find yourself finding this, right, which is the fetal pole with a fetal heart rate. And I just kind of want to go through how we measure this. You're putting, cardiac activity. You're looking for. Essentially, you'll usually find this if the fetal pole exceeds about 5 millimeters by transvaginal or 10 millimeters by transabdominal ultrasound. You're expecting to find this around 6 weeks of gestational age for transvaginal and 7 to 8 weeks for transabdominal. The fetal heart rate must be above 100 to be consistent with good fetal outcomes. And one important fact here is never use the Doppler, always use the M mode. And what you're measuring is these ticks or these flutters that is captured on M mode. It's a little closer image of what that is. So you're going to place, fetal heart rate is best found by placing your probe on M mode. The spikes are noted here, and essentially you're just doing the beginning of one spike to the beginning of the next one, or the end of one to the end of the other, and measuring your heart rate. And if you're doing it correctly, you see the heart rate that's calculated below. So you may also see an empty uterus. And so in the case of an unstable patient, the finding of an empty uterus in a patient with a positive HCG completes your workup. If your patient's unstable and they have an empty uterus, then you are dealing with ectopic pregnancy, and this patient needs to go to the OR. In a stable patient, your disposition is much more difficult because you're going to have to just do a little bit more reasoning on what potentially could be going on, and that might require further imaging, such as a transvaginal ultrasound. I want to talk about the pseudogestational sac, and I think this is what actually ended up happening, what potentially happened to the patient that we had come in. I think there may have, sometimes if you see this structure, right, this is a kind of, it would be dangerous to kind of call this an intrauterine pregnancy, but essentially it looks like this might be a gestational sac, and you might think that this little like flicker of substance might be the yolk sac, but it just doesn't add up, right? There's no decidual reaction, there's no clear yolk sac, and there's no clear, the only thing that's kind of clear here is that you have a gestational sac, but no real yolk sac with decidual reaction. So kind of keep in mind that you might see the structure and be like tempted to call it an IUP, but it's not. I want to talk about molar pregnancies very quick. So these are, in the setting of an astronomically high HCG, you're seeing a patient with hyperemesis with signs of like hyperthyroidism. And essentially when you put your probe down, you'll see this snowstorm appearance, which is essentially just a clutter of small cysts in this homogeneous mass. Better visualized here. Also, another thing, you can have an extrauterine pregnancy where a clot around an extrauterine pregnancy that might mimic a gestational sac with a yolk sac, just like seen here. This is also an ectopic pregnancy. I mean, the uterus is here, and you might think that this is an IUP. So you want to look for your homogeneous structure, the uterus, look for the bladder in relation to the uterus, and know that if you're too far off, then this is not an IUP, and you might actually be looking at an ectopic pregnancy. So just take some orienting. And then interstitial pregnancies. These are pregnancies that are embedded in the myometrium. And essentially what you do here is you want to measure the myometrial mantle distance, and that is a distance from the gestational sac to the end of the myometrial mantle at the thinnest portion, and it can help you distinguish whether or not your pregnancy is in the endometrium or if this pregnancy is implanted somewhere else, like the myometrium. And the accepted value that we use here is that the distance should be greater than 8 millimeters. So if it's less than that, then you should be concerned that this might be implanted in the interstitium. I want to talk about management. I think, after reading about all the pitfalls and the ambiguous nature of the HCG, and I kind of started to get a little, I think it's fair to be a little concerned about, patients that you might be sending home. The study made me feel a little bit better. It's a study from 2004. It was a prospective observational study in a tertiary referral early pregnancy unit in an inner city teaching hospital. It was 179 women with ultrasound diagnosis of ectopic pregnancy. These were clinically stable women with non-viable pregnancies and no signs of hemoperitoneum, who were managed expectantly on an outpatient basis. They found that if the HCG was very low, that is less than 175, 96% of them actually resolved without any intervention. And if they were greater than 1,500, only 21% resolved. The vast majority of of our patients lie somewhere between the 175 and the 1,500, and only a little over than half of the patients have had a resolution of their ectopics with expected management. I want to talk about methotrexate as a management option as well. I feel like this is something that I didn't really know too much about. So who can get methotrexate and why it's important? I think many times we're either waiting for the patient to come back and get their repeat testing for us to see that the HCG is downtrending in an appropriate manner, or we're waiting for the ectopic pregnancy to rupture. And we're only leaving the patient with two choices. That is whether they will clear this pregnancy on their own, or whether they're going to need surgery, which we all know is not really a benign process. So who can get methotrexate? Who can we give this to, and with the help of OB-GYN, obviously. So these are small ectopics, less than 4 centimeters. And if there's cardiac activity, they have to be less than 3.5 centimeters in diameter. HCG needs to be less than 5,000. It might not work if it's higher than that. They need to be stable. If they're unstable, obviously they're going to the OR. You need to have really good follow-up. They need to come back every 2 days to get labs drawn to check the HCG and make sure it's downtrending to 0. They need normal kidney and hepatic function. These drugs are hepatotoxic and nephrotoxic. And if the HCG is greater than 4,000, there's a chance they won't have a good outcome about 35% of the time. If they've had a prior ectopic, they might fail this treatment as well. And again, important to know that this is an option and that most patients don't want to do elective surgery. This is my final slide here. This is just a quick little algorithm that I created with the help of other resources. If you have a patient with any of these two on the top, you have pelvic pain, abdominal pain, vaginal bleeding, unexplained hypotension, you can kind of go down this pathway. You're going to do a qualitative test that is the urine HCG, and if it's negative, ectopic is excluded unless there's a false negative there, which is very, very rare. If it's positive, you're going to go through your history, your physical exam, your transabdominal ultrasound, and if all three criteria are noted on the transabdominal ultrasound, then you have an IUP, and ectopic is excluded. One key note there is that you always want to assess your patient clinically. If there is an IUP, but they're still in a lot of pain and you're concerned about ectopic and there are the correct risk factors, then you also want to consider heterotopic pregnancy. That is something that is increasing with the use of IVF. But if you don't find anything on the transabdominal ultrasound, you're not able to actually confirm an IUP, then you want to move down and get a quantitative beta HCG to begin the tracking and trending of that value and get a transvaginal ultrasound to see if you can visualize an ectopic or not. And if you do see an IUP with the transvaginal, again, ectopic is excluded, but it's the other pathways that can sometimes be a little bit more difficult. So, if there's pathological fluid, such as moderate to large fluid on the transvaginal ultrasound, but no IUP and no ectopic, I think that prompts a guidance consult to kind of get more insight on what we might be missing. If there's pathologic fluid and an ectopic pregnancy, they're going in for emergent surgery. And if there's no pathological fluid, no IUP, and no ectopic, you want to think about getting a gyne consult and having the patient return in 48 hours for serial HCG testing. Importantly, I didn't include the patient who is unstable or the patient who is stable and has a positive FAST. I think those patients, again, need urgent gyne consults and emergent surgery. And these are my references. Thank you, guys.